Okay, good evening. I am Mark De Leon from the Philippine Glaucoma Society. I will be your moderator for this evening. So let me start with opening remarks from Dr. Manuel Delfin, the President of the Philippine Glaucoma Society. Dr. Delfin.
Okay. Thank you, Mark. Thank you very much. Well, I'd like to thank everybody. Welcome everybody tonight for this webinar. And in these times of the pandemic, and each of us in our homes, the learning doesn't stop, and we hope that you still continue to read and to learn more about our craft or our specialty, and so that you can apply it when we start our clinics again, maybe in the near future. So I'd like to thank Mark De Leon for setting this up, and thank the PAO for helping us in setting this up also. I'd like to thank the president, Dr. Marge Latluna, for keeping this forum open for everybody and to keep the learning going on. I'd like to thank our speaker, who will be introduced by Dr. Cinch Verzosa, and he's a very good friend of PGS, and I hope you learn a lot from this. So again, welcome everybody, and stay on, and hope you learned something from this webinar. Thank you very much, and welcome.
Thank you, Dr. Delfin. So Dr. Cynthia Versosa will introduce our speaker. So Dr. Cynthia Versosa is a PGS board member and a PAO board member. She will introduce our speaker, Professor Tin Aung from Singapore.
He is currently the Executive Director of the Singapore Eye Research Institute, the Deputy Medical Director and Vice Chair for Research of the Singapore National Eye Center, and a Senior Consultant of the Glaucoma Department of the same center. He is also a Professor of the Department of Ophthalmology of the Yong Lu Lien School of Medicine of the National University of Singapore, and at Kwan Im Thong Hu Cho Temple Professor of Ophthalmology of the Duke and U.S. Medical School. He is a clinician, scientist, and researcher, having produced over 500 publications. He has trained a lot of Filipino ophthalmologists in the field of glaucoma. He is an honorary member of the Philippine Glaucoma Society. Tonight, he will talk about the current management of primary angle closure suspects, lessons from the ZAP and Annalise trials. Fellow ophthalmologists, please welcome Professor Tin Aung.
Thank you very much. I'd like to thank the PAO and the PGS for inviting me for this webinar. And I know it's a very tough time to be away from our patients and to be stuck at home in quarantine or in lockdown. And I'd like to thank Mark De Leon for organizing all the logistics for this seminar. So I'll be talking today about how should we manage angle closure suspects, which is probably a common scenario in your practice in the Philippines. And I'll be giving you some data from recent trials, one in China called the ZAP trial, and a second from Singapore called the Annalise trial, which has not been published yet. So I have no financial disclosures. So as Mark said, I come from Singapore, and it's usually a very crowded place and full of people. And as you know, we have about almost 6 million people in a very small area, smaller than Manila. But these days, this is what Singapore looks like. You can see there's empty streets and empty restaurants and shops. In fact, most restaurants are only open for takeaway, and no restaurants are open to serve food at the place. And even our usually bustling MRT is very empty because most people are working from home. And there's almost like a partial lockdown with only limited people working every day. And this is some scenes of Changi Airport. And as you know, it's usually a very busy airport. but you can see that it's a very empty. There are only probably like less than 10 or 20 flights a day still flying from Changi. And I used to fly every month, maybe at least 2 times a month, and I haven't been to Changi Airport since February. So it's like a long lost friend. So today we are talking about angle closure glaucoma. And as you know, it's an important form of glaucoma, especially in Asia. It affects more than 20 million people. And there's a spectrum of angle closure glaucoma disease. So we know that for most populations in Asia, the prevalence of angle closure glaucoma is about 1 to 2%. But about between 5 to 8% of the general population above the age of 40, at least in the Chinese populations, have something called narrow angles or angle closure suspect. As you know, this is the earliest stage of the angle closure process. So you can see that if you look at at least from the prevalence, about 5 to 8% have narrow angles, but only 1 to 2% have angle closure glaucoma. And just from that data alone, you can know that most of the angle closure suspects do not progress to angle closure glaucoma. And so the progression rates are very variable. If you look at hospital-based studies, people will say that, from suspects to primary angle closure, as much as 30% may progress over 5 years. And from angle closure, PAC to PACG, maybe in 10 to 30% over 5 years. So the data is usually very high based on hospital data. And so that makes us very worried about how we should manage angle closure suspects. So let me share a common example of a case. And this is probably a patient that you may see in your practice. A 59-year-old woman who has no symptoms of angle closure, or has no pain or acute signs of acute angle closure. She has a hyperopia of +2 diopters. And she came to see you for just a mild visual disturbance or blurring of vision. On examination, she has a bit of a very mild cataract, a shallow anterior chamber, and the vision is good with best correction goes down to 6/6. Her intraocular pressures are normal, her visual fields and optic disc are normal, but on gonioscopy, she has appositional closure of both eyes and more than 270 degrees of appositional closure, but no synechia, no PAS. And this is a picture of the anterior segment OCT. And you can see this patient has obvious appositional closure in both both angles you can see here. So this is a patient who has a diagnosis of PACS or primary angle closure suspects because she has narrow angles, but normal intraocular pressure, no PAS, normal disc, and no glaucoma. She also has minimal cataract. So in your practice, how will you manage this patient? So narrow angles, just narrow angles only. So these are the options I'll give you. And in your mind, think about whether you would do a laser iridotomy in both eyes. Would you give her a pilocarpine treatment for both eyes? Would you offer her bilateral phacoemulsification? Or would you just observe her? And these are the 4 options for you. And think in your practice what you would do. I think most people would either say laser iridotomy in both eyes to prevent angle closure glaucoma or observation. And these are probably the 2 most common examples, unless you are extremely aggressive phacosurgeon and you may do a phaco in both eyes. Now remember, when we see this patient and we tell her, we'll observe you, you will always worry about being sued. What if the patient, if you say you observe her, and she gets an acute attack of angle closure in the next 1 week? Or maybe she comes back a year later with chronic angle closure glaucoma and extensive visual field loss and disc damage. Will you be liable? Will you be sued because you had the patient when she had just had narrow angles, but you are elected to observe the patient and she came back with significant visual loss or visual morbidity? So this is your big worry in your practice. And I'm sure all of you who are in private practice will always worry about this scenario. Remember, we have a prophylactic treatment, laser iridotomy, which is used to treat the pupil block element of angle closure. It can prevent progression. It can prevent acute attack and blindness. Of course, you must also remember that laser iridotomy has some adverse events or effects. For example, maybe up to 20% of patients have visual symptoms due to the iridotomy, causing glare or lines or some visual disturbance. You may also have a risk of corneal endothelial damage. It's not a very high risk, but there's a risk is still there, as well as progression of cataract. So there are some adverse events after iridotomy as well. So this is the stage for why we did these two trials, the ZAP trial and ANALYST trial. It's basically to get data on how to advise you to counsel your patients with PACS regarding laser iridotomy, to counsel you to know what are the risks and benefit of doing a laser iridotomy, and what is the risk of progression when you just observe the patient. And also we wanted to find out who are at greatest risk of progressing from PACS to PAC or PACG. Remember, if you have a 5 to 8% of everybody above the age of 50 have narrow angles, there's a high economic burden of treating all PACS in the population. And in the old days, we used to think that perhaps this is a strategy to prevent angle closure glaucoma. We screen everybody with narrow angles and offer everybody a PA or PACS, a laser iridotomy, to prevent them from getting angle closure glaucoma. So this is the setting for the trial. We wanted to know, is it a viable strategy? So we did two studies in parallel, actually. The Zhongshan Angle Closure Prevention Trial, is in short, is the ZAP trial. It's a very catchy name. And the name is because the center is the Zhongshan Ophthalmic Center, which is in Guangzhou in China. And of course, because we're looking at angle closure prevention, it comes with a very catchy name, the ZAP trial. And this was published last year, and there was a trial which we looked at the prevention of angle closure. It's a randomized controlled trial looking at the effect of laser iridotomy. And it was published in the journal called The Lancet. So the reason why we did the trial, as I said, is to help us manage asymmetric narrow angles or PACS. And the background of the trial is we did a randomized controlled trial in which we recruited patients with bilateral narrow angles, all above the age of 50, and one eye was randomized to iridotomy and the other eye had no treatment. So it's an intra-patient controlled trial. And they were followed up for 6 years and recruited 900 patients in total. And then we did a parallel trial in Singapore, which I'll come to later. So very simple trial design, bilateral narrow angles, laser in one eye and no treatment in the other eye, and followed up for 6 years. And we wanted to see the primary outcome was the incidence of primary angle closure, which was defined as either you developed IOP above 24 on 2 separate occasions, or you developed synechia, or you got acute angle closure. Of course, we also looked at other outcomes, including development of angle closure glaucoma. But remember, the main outcome was the incidence of PAC. And the ZAP trial recruited almost 900 patients. The mean age was 59.3, and there were more females than men. And most people had the iridotomies superiorly, and some were either nasally or temporally, depending on where there were crypts. And as I said, they were all followed up, and almost 75% of patients completed the study. So after 6 years, what was very surprising was that a very low incidence of the primary outcome. So only 19 of the laser eyes versus 36 of the untreated eyes reached the endpoint. So this was a cumulative incidence of, if you give per 1,000 eye years, is 4.19 per 1,000 eye years, or 7.897 per 1,000 eye years. Okay, and so it shows you that the group that was treated by laser had lower incidence of reaching the endpoint or progression. And this was significant. So if you look at the gross numbers, you would say that, okay, 2.1% progressed in the laser group versus 4% in the untreated group. So this was about half the risk, reduction of risk by doing the laser. But however, it was very low overall. You could see, as I told you before, in the earlier data, we thought maybe 30% will progress. But actually, without treatment, only 4% progressed in this trial. And this is a 6-year follow-up versus 2% in the laser trial. And those who progressed were those who had narrow angles at baseline, which is perhaps not surprising. But we did not find any other risk factors for progression apart from baseline intraocular pressure was not significant. And they also did a dark room provocative test, which was also not significantly associated with reaching an endpoint. Now, as I said earlier, this was very surprising, and it shows you a very low incidence of progression. But of course, if you do the iridotomy, you reduce the risk by about half. And the iridotomy itself was safe, and you had no long-term adverse events. Now remember, the majority of endpoints was primary angle closure. In fact, only 5 eyes, 4 in the untreated group and 1 in the acute group, reached acute angle closure. The rest, all of them developed either high intraocular pressures or developed PAS. And there were very few cases of primary angle closure glaucoma. So what is the trial recommendations? This shows you that really doing nothing was also a very low risk. And this was very interesting. And certainly for a programmatic level and on the population level, we cannot go around anymore to recommend to governments to do a screening for all narrow angles in the population and do iridotomy for all of them because it's not cost effective. Now, the ZAP trial, of course, is a Chinese population. And so you may say in the Philippines, it may not be applicable, where we don't know about the Philippines data. But remember, Chinese population is quite a high risk of angle closure glaucoma. The second thing was that the mean age of the ZAP trial was 59 years. And this is so-called maybe a younger population. They were not the older people who are maybe over 70. And the reasons why is because we recruited people who did not have significant cataract. And so this is a population which are the more relevant to us because if they have significant cataract, they can just undergo cataract surgery. So this was the more relevant group who have not much cataract. As I said, as I showed you my case earlier, just have narrow angles. Another issue with the ZAP trial was that they were recruited from a community setting. So basically, they went around to one region of Guangzhou and asked all the people who were above the age of 50 to come for screening for narrow angles, and then they recruited them. So perhaps they were not a hospital-based cohort. Let's move on now to the Singapore study. And the Singapore study doesn't have a catchy name like ZAP, and we called it the Analyst trial, or the Asymptomatic Narrow Angles Laser Iridotomy Trial, Analyst. Now, I had a lot of people disturb me in my hospital. They call it the anal trial because they say you put the hyphen there between the ANA and the LIS. But never mind, this is the Analyst trial. And again, we had the same study design, recruited people with bilateral narrow angles above the age of 50, laser in one eye and no treatment in the other eye. And this time followed up for only 5 years, a slightly shorter follow-up. And we recruited about 480 patients. And this trial had just been finished about a year ago, and we are about to submit the paper. And we found that in Singapore, the progression rate in the untreated arm was about 9.5% versus 5% after iridotomy. So again, you can see about half the risk, but much higher than ZAP. And of course, the no intervention increased your risk, or that means intervention reduced your risk by half. And the endpoint again was PAC, and only 3 eyes got acute attack, 2 in the untreated arm and 1 in the treated laser arm. And the laser arm that could acute attack was because the iridotomy is closed off after the patient developed some uveitis. We found some risk factors for progression, such as narrow angles at baseline, same as ZAP. We also found higher baseline IOP, higher post-dilation IOP at baseline. It means after all patients, we dilated them at baseline, and those who had a bit of a rise in IOP were at greater risk of progression. And people with diabetes were also at risk of progression. So this is some interesting data here. So if you compare the two trials, you will see overall ZAP untreated 4, Singapore untreated 9, treated 2 and 5. So overall, again, very low risk of progression, but Singapore was slightly higher than ZAP. Now, why the difference between ZAP and Analyst? Well, as I said earlier, ZAP was community-based, whereas in Singapore trial, we recruited all patients from the hospitals. So these were patients who already came to the hospital for some reason or other, and so probably they were a slightly more risk. We also had people who, in the ZAP trial had slightly wider angle width in the ZAP trial compared to Singapore at the baseline. And of course, Singapore also has a racial differences because we had some about 20% who were non-Chinese compared to all Chinese in the ZAP trial. Whatever it is, both trials show you the evidence of very low risk of progression for PACS. Remember, less than 10% in Singapore and about 4% in ZAP. And again, the endpoint was only PAC, no, not angle closure glaucoma. So it's debatable, is PAC serious enough in a way, because PAC is not a blinding disease. You only have synechia or you're a bit of high pressure. So it's not like they have glaucoma. And again, it's not an endpoint of glaucoma. And again, both studies make us think about whether we are over-treating PACS if we do iridotomy for these patients. And remember, the other question we wanted to answer was at a population level versus the clinic level. And at a population level, certainly, we don't recommend doing iridotomy for PACS, but at a clinic level or a patient level, it's different. And I'll explain to you in a while. So how should you manage your patients with PACS? So currently, this is how I manage my patients. I will give them now the data. I will tell them, we have 2 big trials, and both trials show very low risk of progression if you do nothing. And overall, if you see, as I told you, about 10% in Singapore and about 4% in China. So a low risk of progression in both trials. And even if you progress, you only progress to PAC and not PACG, and very low incidence of acute attacks. And of course, I will tell them the option that if you do laser, you reduce the risk by half. So it does reduce the risk overall. And so I'll explain the risk of both laser as well as doing nothing. And I will let the patient decide, tell the patient, these are the 2 options, and let the patient decide. If the patient is a type who are worriers and they don't want to take any chances, I say, of course, go ahead and do the laser. It reduces the risk significantly. But if the patient says, okay, I understand the risk, let me observe and come back to you and see what happens, then it's fine. I will document it. Yes, patient understood the risk and decided to observe. Now, some patients say, oh, they're not sure. I'm not sure what to do. Can you decide for me? In such cases, usually I tell them, okay, go ahead and do the laser, because these patients may not understand fully or they don't know what we are talking about. And so I would rather err on the caution and offer them a laser. Now, how about older people with cataract or people with cataract even at a younger age with PACS? Of course, I would just say, do the cataract. But no need to do the laser, just take out the cataract and this will solve your problem. So this is very simple. If you have older patients with cataract, go ahead and take out the cataract. So who should go for a laser iridotomy finally? Remember, all patients with angle closure glaucoma, of course, should go. Those with PAC, of course, should go. And acute attacks, of course, should go, including fellow eyes or acute angle closure attacks. All these people should go for laser iridotomy for sure. If you have PACS and they are symptomatic, that means they tell you they get intermittent eye pain or headaches, etc., and you're not sure, I think go ahead and offer the iridotomy because they may be having intermittent acute attacks in between. Patients who require regular dilation of the pupil, for example, diabetics, sure, go ahead and do the iridotomy. And remember, in our study in Singapore, diabetes was a risk factor for progression. So it's another reason to do iridotomy in diabetics. People who have poor access or poor follow-up, maybe they live in the provinces or they say they can't come for follow-up, I think it's fair enough to offer an iridotomy. Family history is questionable. I usually offer them if they have a significant family history of angle closure glaucoma, especially if they have people who are blind in their family. I would say go ahead and do the iridotomy. We don't want them to get the disease like their family members. And of course, there could be some patient-specific factors or population-specific factors which may be unique to your population. I don't know about the Philippines, whether there are some unique factors in the Philippines that may make you more inclined to do it iridotomy. So in summary, I think today I've shared with you the data of two big trials. One was the ZAP trial in China, and the second was the analyst trial, both of them looking at the management of primary angle closure suspects. Remember, in both trials, we did a intra-patient control design, randomized to one eye iridotomy and one eye without treatment. And we followed up the patient for 6 years in the ZAP trial and for 5 years in the Singapore trial. And we were very surprised with the findings. We found overall a very low risk of progression in the untreated arm. Only 9.5% in Singapore and 4% in China progressed. If you did iridotomy, the risk of progression was reduced by half. So from 4% it went to 2%, and from 9.5% to 5%. So this gives us good data on the option of observation in patients with PACS. So remember, now we have good data, you can discuss the risk with the patients. And of course, if the patient is in doubt or the patient is a worrier, go ahead and do a laser iridotomy. If the patient has cataract, of course, offer cataract surgery. And I hope that this data will be helpful to you when the next time you see a patient with PACS or narrow angles. I'd like to acknowledge the list of research fellows in Singapore who I've worked with, especially many of them have worked on the ZAP trial. It's been a long trial. We took 3 years to recruit all the patients in Singapore. And this is because our recruitment rates were slow. That's why we ended up the trial much later in China. In China, Ling Guanghe from Guangzhou, he recruited all 900 patients in like less than 6 months. And this shows you the power of recruitment in China, in Guangzhou. Of course, I'd like to acknowledge Professor David Friedman and Paul Foster from UK, who helped with the study design and protocol generation. And in Singapore, we had Paul Chu from NUH and Wong Hong Tim from Tan Tock Seng, who are the Singapore sites in the analyst trial, as well as my colleagues from SNEC, who also helped recruit patients for the trial. I'd like to thank you for your attention and welcome questions from anybody in the audience. Thank you.
Thank you very much, Prof. I have some list of questions coming in. First question is, how about corneal endothelial cell counts in those patients that had laser in these studies? Were they significant?
Okay, that's a very good question. In the Singapore trial, we found that there was a slight greater loss of corneal endothelial cells in the laser group compared to the untreated group. Now, both groups showed a loss of endothelial cells over time. And of course, we think this could be age-related. Also, people with PACS tend to have a shallow anterior chamber, and this may also be a factor behind loss of endothelial cells. And there was a slightly greater loss of endothelial cells in the laser group compared to untreated group. But in the ZAP trial, there was no significant difference. So we don't know whether this is how this will pan out. But I suppose there was a slightly greater loss in the Singapore trial, but there were no cases of corneal endothelial decompensation.
Thank you, Prof. How about cataract development in the laser arm?
Yes. So in the Singapore trial, both arms had similar rates of cataract progression and similar rates of cataract surgery. So there were some patients in both trials who underwent cataract surgery during the follow-up. So these are called censored data. Once you go for cataract surgery, they're censored. But there was very low, overall less than about 5% went for cataract surgery during the trial in both arms.
Okay, thank you. Other questions are coming in. Is a shallow central ACD a risk factor for progression to PAC?
The anterior chamber depth alone was not a risk factor, but remember, these are all people with narrow angles. So we don't have the ability to tease out within this group. Of course, anterior chamber depth, shallow anterior chamber depth is a risk factor for angle closure in general, but remember, these are all people with narrow angles. So we don't have enough power to distinguish shallower within this group. Everybody had shallow anterior chamber.
Thank you. Another question is, for observation, what's a good gap of time in between follow-ups, assuming regular follow-up is not an issue?
That's a good question. So in Singapore, I usually tend to follow my patients every 12 to 18 months.
Okay. Another question: what was the power of the laser, and how many shots? Probably this could affect endothelial cell loss. So, what was your optimum laser power and the number of shots?
Okay, so in the Singapore trial, we did a sequential argon YAG laser. So basically, we did argon pre-treatment followed by YAG. So usually our argon laser settings is 50 microns, 0.05 seconds, starting with 0.5 watts to 0.7 watts, and we usually do about 10 to 15 shots pre-treatment to cause like a shell, small crater. And then YAG, we just do usually 1 or 2 shots only, using about 1.5 to 2 millijoules. So it's not a very high energy. In the ZEP trial, they only did YAG iridotomy, and it was a one-time YAG. They started with 5 millijoules.
Thank you. Is there an advantage of doing 2 iridotomies compared to just 1?
Okay, so there is no data to show that, and usually one iridotomy of at least 200 microns is supposed to be good enough to prevent a pupil block. So there is no evidence of doing 2 iridotomies, unless you worry that there's some issues with inflammation or something. But usually no, just you have to do 1.
Thank you. Do you look at the refraction or the anterior chamber depth of the patients that converted to primary angle closure?
Yes. So as I said again, because this is everybody was PACS, so we didn't have the power to distinguish with them. But there was not a significant factor. But everybody was either slightly hyperopic or close to emetropia, because this is all PACS. So we don't have people who had very high hyperopia. We didn't have many people who had high myopia, for example. So it was all very close to the emetropia refraction.
Thank you, Prof. If you translate the findings of these 2 trials to need to treat, so how many PACS do you have to treat to prevent one from progressing?
Yes. So the Singapore data was 19, almost 20. So you had to do 20 to prevent one. And the ZEP was even more. I think it was 30.
30, yes.
Yeah. So in terms of NNI, number to treat, is not a very good number in terms of on a population level.
Okay. So any more questions? Any more questions from the floor, from the group? So it seems like what time is it? It's 7:30, 7:34. Any more questions?
So can I ask, in the Philippines, do you normally offer iridotomy in your practice? Maybe we'll ask Cynthia.
Cynthia? Cinch, are you around? I think Egay. I think Egay is around.
Yes.
Is Cinch around?
Yes, Mark.
So do you normally offer iridotomy PACS in your practice?
Yes, most of the patients who come in are hospital based and they're normally worried. So the threshold for doing LI is quite low. That means that we normally do maybe more than 50% of patients with shallow chambers, and shallow ACD. We normally offer laser iridotomy.
Okay.
There is a question about iridoplasty. So, was there any iridoplasty done in any of these trials?
No, the iridoplasty was not done.
Another question: do you do sequential? Well, maybe not related to the trials, but maybe in your practice, do you do sequential gonioplasty, iridoplasty with an LI, or would there be certain factors that lead you to do it and certain factors that lead you not to do it?
Okay, so usually we don't do iridoplasty. We will do just an LI first. But in some settings, for example, in acute ankle closure, sometimes we will do iridoplasty to break the acute attack. The second group of people who do iridoplasty are people who are post iridotomy with persistent apposition closure, and we want, especially if there's plateau iris configuration, we want to open up the apposition with iridoplasty. So these are the people we will consider. But iridoplasty has got some risk, particularly we worry about corneal endothelial damage, and also some people get pupil irregular pupils, which causes visual disturbance. So these are some issues we're doing in iridoplasty.
Thank you, Prof. Well, so far that's it. I don't think there are any other additional questions unless, oh, there's one more here. Was iris thickness considered as a risk factor for progression maybe through the spectrum of angle closure, iris thickness?
Yes, it's a very good question. So in terms of if you compare people with a narrow angle closure versus the normal people, iris thickness is actually a risk factor. The thicker your peripheral iris, the greater your risk of developing glaucoma or angle closure glaucoma. However, in this trial, we are now analyzing the anterior segment OCT data, but so far we haven't found iris thickness to be affected. But unfortunately, the anterior segment OCT was not performed in everybody, so only a certain number of people underwent anterior segment OCT at baseline because the OCT was only available like halfway during the trial. So unfortunately, we don't have that good data on that.
Okay, thank you. There's one more question. I'm going to read it. Only 5% opted for cataract surgery versus LI.
No,
That's the.
this is not. In the trial was LPI versus observation, but unfortunately, during the prior trial, some people did not develop cataract. So remember, in the trial at the beginning, we did not recruit people with significant cataract, but some people got progression of cataract, and about 5%, 1 to 5% underwent cataract surgery during the trial. So this is what I meant by they underwent cataract surgery, 5% went during the trial. It was not at the baseline.
Okay, thank you. So I think that's it, unless there are no more questions. Any other questions from the floor? Oh, there's one here. Did the OCT or UBM play a role in the screening?
No. The screening was all based on gonioscopy, but we did OCT at baseline for more than half of our patients to look for additional risk factors for progression.
Okay, thank you. So I think that's it. There are no more questions from the floor. So thank you very much, Prof. So the last thing on the agenda is the closing remarks. Unless there are no more questions, thank you very much for enlightening us about the management of primary angle closure suspects or occludable angles, which I think is very important in our practice these days. So
thank you very much.
Thank you. So I think for the last session, Dr. Marge Luna, the president of the Philippine Academy of Ophthalmology, will give the closing remarks. Dr. Marge Luna.
I can't start my video. Wait. Start your video. Okay. Prof, on behalf of the Philippine Academy of Ophthalmology, I'd like to thank and congratulate you for another excellent lecture. And you said so yourself that you were surprised by the results of the studies that you presented, and your talks drive home the point that really nothing beats evidence. And thank you for sharing with us, letting us catch a glimpse of Singapore during the lockdown. And we wish that we could send you your favorite dish from Locavore, but
Yes.
for now, we can just send you a certificate of our appreciation and our best wishes. So thank you very much, Prof. And I'd also like to thank the Philippine Glaucoma Society for organizing this webinar. to our moderator, Mark, our panelists, and our technical team. So thank you very much, Prof.
Bye
Bye.
bye.
Uh,
Bye everyone.
Bye bye.
bye, Mark.
Bye.